Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, I share my over 25 years experience to guide both men and women as they age. Listen as I discuss a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. It's happening to all of us, so listen for some solid scientific knowledge on how to handle these changes. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. It's now December, and UTIs, or bladder infections, for whatever reason, seem to increase as we get closer to the holidays. I don't know if it's people's stress level going up, or they're not taking as healthy care of themselves, or maybe they're just more sexually active with their partners around the holidays. But I'm a urogynecologist, and we definitely see a little bit of an uptick in UTIs close to the holiday season. So today, let's talk about recurrent UTIs, what the definition of that is, what it means for patients, and what we can actually do about it, because there's a lot of misconceptions about it. A urinary tract infection is a general term for a bacterial infection anywhere in the urinary system. That can be from the kidneys through to the bladder. A kidney infection is called a pyelonephritis, whereas a bladder infection is called a cystitis. But very often, the terms UTI, bladder infection, and cystitis are all used interchangeably. And there is a formal definition for recurrent UTIs, and that is a patient who has more than 2 UTIs in 6 months or more than 3 UTIs in a year with full treatment and resolution of their symptoms in between each UTI. So this is a little bit different from a patient who has a UTI and gets treatment, doesn't really feel better, or has the symptoms come back just a few days later and gets a second treatment, and maybe still doesn't totally feel better and gets a third treatment. That's a persistent infection, and I'm not going to specifically address that today. We're talking about a patient who has a UTI, is treated, feels better, but then 2 or 3 months later has another UTI, is treated, and then feels better again, and then once again, 2 or 3 months later, another UTI. When patients have a UTI, the classic symptoms of it are pain or burning with urination. That can be pain when you're holding your urine, pain as the urine is passing. It can increase urinary urgency and frequency, and sometimes even the new onset of urinary leaking or incontinence. These classic symptoms of a UTI are very common in young patients under the age of 50. And if you've ever had one, once you feel it, you know exactly what it is, and you don't want to have it again. You want to be treated right away. As women get older, though, the symptoms of a UTI start to change, and that pain or burning with urination that's so classic for a UTI starts to go away. Many women over the age of 50 who've been diagnosed with a UTI say they have no burning when they urinate. They might notice cloudy urine or a urinary odor. They might have lower abdominal discomfort. They certainly can notice urgency, frequency, and incontinence, but this group of women is already experiencing those symptoms as a baseline. So sometimes it's a worsening of those symptoms or a new onset of those symptoms. They can also have vaginal irritation or burning or swelling feeling. I've heard all of those symptoms in patients over age 50. In our elderly patients, sometimes the only marker of a UTI is a change in their mental status, where the patient is more confused, doesn't remember things quite as well. In fact, a lot of my daughters who are helping to take care of their elderly moms will bring their patient in to say, "Mom's just not herself. Her mind is a little bit different. I'm concerned she has a UTI because this is what happened the last time she had one." Typically, when a patient presents with possible symptoms of a UTI, your physician is going to get a urine sample and do an office dipstick. So this is a little strip that's dipped into the urine, and it quickly gives us a snapshot of whether there are white blood cells present in the urine, red blood cells like blood present in the urine, and the presence or absence of bacteria in the urine. It is by no means a definitive test, and there are lots of things in our diet and in our hydration that can affect the urine dipstick. If the urine gets sent to the lab for testing, the lab will typically do a urine microscopy and a urine culture. A urine microscopy sounds exactly like what it is. The pathologist looks at the urine under the microscope and can actually give us a numerical count of how many white blood cells are present, how many red blood cells are present, if there are crystals in the urine, which might be associated with a kidney stone. So it's a little more objective information as compared to a urine dipstick. But the urine culture used to be thought of as the gold standard for diagnosing a UTI. The urine culture has been used since the 1900s, and literally it's growing your urine in a culture to see what type of bacteria grow. Many, many years ago, there was an arbitrary cutoff made of if there were more than 10 to the fifth colonies of bacteria growing in the urine culture, that was considered a positive urine culture. But in 2024, the urine culture has a lot of limitations. It is very likely that a patient does have a symptomatic urinary tract infection if they have symptoms of a UTI at a much lower level of bacteria. So there shouldn't just be an arbitrary cutoff for the urine culture. The urine culture should really be used as a tool in conjunction with the symptoms that the patient is reporting. And of course, the bacteria that we're exposed to now in 2024 is very different than the bacteria we are exposed to in the 1900s. And there are many types of bacteria that are simply not able to be cultured with a urine culture. The urine culture was designed to find E. coli. And E. coli is still the number one infector of the urinary tract. So it's a good test to find E. coli. It's not a good test to find a lot of the other bacteria that we see causing UTIs today. Plus, we also have to look at the source of the urine. For most women, they're told to go into the bathroom and pee into a cup. That technically should be called a clean catch urine. And if you're lucky, you'll be given some instructions on how to properly collect a clean catch urine, even though I know many women are not given any instructions and just told to go pee in a cup. But the way we are supposed to properly collect a clean catch urine is this. You go into the bathroom, you separate the lips of the vagina, the labia, and hold them open the entire time. You clean around the opening of the bladder, which is the urethra, with some cleaning wipes. You begin your urine stream into the toilet. That first part of the urine stream that lands in the toilet is supposed to flush out any surface or skin bacteria. Then you take your sterile urine cup and put it under the urine stream to catch a midstream sample and take the urine cup out before the stream ends. Not an easy task when you're in the doctor's office bathroom and you're trying to hold the labia open with one hand and stick this urine cup in and out of your urine stream without getting urine all over your hand or all down your lap. I know for sure that the overwhelming majority of women are not following all of these steps to get a truly clean catch midstream sample. It's really challenging to do. Plus, if you're a young woman and you're on your period, it's very likely that some of that menstrual blood is going to contaminate the sample. If you have any type of vaginal infection, sometimes some of the vaginal secretions can contaminate that sample. At no time should the urine cup touch your body because we don't want the edge of the urine cup to come in contact with any normal skin bacteria. This is just a challenging thing to do. So in my office, our standard, because we tend to see patients with recurrent UTIs or complicated UTIs, our standard is to get a catheterized urine specimen. Catheterized urine specimens are the most reliable because we can then guarantee that the urine sample has come directly from the bladder. It is not contaminated by any vaginal secretions, any menstrual blood, any skin or surface cells. Now, I will tell you, anytime a woman hears that she's going to have an in and out catheter to collect a urine sample, there's a lot of fear associated with that. Is it going to hurt? What's it going to feel like? I'm very nervous about it. I have done catheterized urine samples for women for over 20 years. And earlier in my career, I didn't want my patient to be overly fearful when I was about to drain her bladder with a tiny little catheter. So many times I would get ready to do the exam, not verbally tell her. I would say something like, I'm going to collect your urine now, but not use the word catheter. I would drain out the bladder, hold up the urine sample that I just collected with the catheter, and say, great, here's the urine I just drained from your bladder. This is the sample we're going to use for testing. And invariably, women were shocked when I showed them that urine cup. And the most common response was, where did you get that urine? And I'll say, I just drained it from your bladder seconds ago. And many of them were in disbelief. They would say, I can't believe that you drained it. I didn't feel anything. So if you have a competent urogyn, gynecology, primary care provider who can drain the urine, it should be painless. We use not a tiny little bit of numbing gel. The catheter we use is very tiny. Most women aren't even aware that it's happening. Now I will tell you that I got so many people shocked that they did not feel the catheter. Sometimes it would show up on their EOB, their explanation of benefits, that we had charged the insurance company for the placement of an in and out catheter and the urine test. And they would call my office angry and say, I didn't have this test. I would have known if I had a catheter in and out of me. And I have to speak with them each individually and say, I promise you I did this. It is my standard of care. I do it for every patient with your symptoms. You absolutely had that catheter. We're just so skilled at it that you weren't aware that the catheter went in and out. So now I've had to change my practice and actually say to women, I'm going to drain your bladder. I'm going to use a tiny little catheter. You're not even going to notice it. I still show them the urine when I'm done, and still many of them are shocked that I was able to collect it with minimal to zero pain. Now, as I said, the benefit of the cath sample is that it avoids all of that contamination. It avoids the challenges of getting a clean catch sample. And I know that the sample that I am going to test is going to be accurate. One of the things that we're learning about the environment of the bladder is that we used to be taught, and we used to teach patients, that the bladder was a sterile place. It should never contain any bacteria at all unless you had an infection. We now realize that the bladder contains a complex community of bacteria and microbes that are likely normal and necessary for bladder health. And that makes perfect sense. We have normal and healthy bacteria that colonize our mouth. We have normal and healthy bacteria that we need in our vagina. We have normal and healthy bacteria that live on our skin and in our colon. All of these bacteria are not infectious bacteria, but actually critical bacteria to keep us healthy. The bacteria in our gut break down our foods. The bacteria in our vagina are part of our vaginal immune system. When we have healthy levels of bacteria in our vagina, it helps us prevent infections. So, of course, it follows that we would have healthy levels of normal bacteria in the bladder that maintain bladder health. And when those healthy levels of bacteria are disrupted or go down, we might suddenly get a pathogenic bacteria in the bladder, and that's what we're calling a UTI. But that's a warning against treating something called asymptomatic bacteria. This is a medical term for a patient who has no symptoms of a bladder infection, but has shown a positive urine culture. In those cases, we typically do not treat asymptomatic bacteria, and that's a good thing. We certainly don't want to overuse antibiotics or wipe out the healthy bacteria that should be there. One type of test that is relatively newly evolved, probably in the last maybe 8 to 10 years or so, is molecular testing. We know that there are lots of limitations to the urine culture, so obviously we need something better. Molecular testing is typically PCR testing, and it doesn't rely on the growth of bacteria in a culture because, as I said, certain bacteria cannot grow in a culture. It just does not have the conditions where that bacteria can grow, and therefore we don't see it. Molecular testing, I think, can be a really important tool, especially for those with recurrent UTIs or complicated UTIs. We need to use caution, though, when we're interpreting the results of molecular testing. So the benefits of molecular testing are that we can pick up a ton more bacteria than we can pick up on a urine culture. So sometimes, just in my own practice, at the same time, I've run a urine culture and molecular testing on a patient who is clearly symptomatic of a UTI. The culture will come back negative, but the molecular testing will come back with one or even more bacteria that I can treat. So in that case, the molecular testing is a home run. Normally, I would have told that patient, hey, your urine culture is negative. You don't need any treatment. But what I was actually realizing is the urine culture couldn't see her infection, and the molecular testing picked it up. Now, just like we shouldn't be treating asymptomatic bacteria, we shouldn't be doing molecular testing in patients who are asymptomatic or just want to follow themselves up, because it's likely that the molecular testing is picking up a lot of those normal bacterial flora, the ones that we want to be there. I think also our knowledge has not caught up with molecular testing of the urine. When I get molecular testing back from urine, I see so many different bacteria. Some of them I've never even heard of. I have to go research them. What type of bacteria is this? And I think we need to use caution and common sense. We don't need to treat every single bacteria we find in the bladder. Many of them are going to be part of that normal bladder community, and we don't want to disrupt them. In fact, there's a term for this. It's called antibacterial stewardship. It means using your antibiotics in an ethical and proper way. We don't want to overuse them. First of all, it causes side effects in patients. It can wipe out healthy bacteria, not only in the bladder, but in the gut and in the vagina. And if we're giving antibiotics when there is not a pathogenic bacteria to treat, we're actually teaching bacteria how to become resistant to that antibiotic. And that makes a population wide problem where we no longer have good antibiotics to treat the bugs that we are facing. So we want to practice good antibacterial stewardship and not just treat everything we see on a piece of paper coming back from the lab, but as always, use the lab in conjunction with talking to our patients and examining our patients and putting it together and making the proper plan of care. So after we've evaluated the symptoms and done the testing that we think is correct, we obviously, in the proper cases, want to treat our patients. So who do patients go to when they think they have a UTI? They're probably going to see their primary care or possibly their GYN. And most of those doctors are going to do a urine dipstick in the office, as I talked about. And in a symptomatic patient who has white blood cells and maybe red blood cells and presence of bacteria on a dipstick, it's very reasonable to begin treatment. That's most likely what it is. Hopefully, the physician is also sending a urine culture off to confirm that the antibiotic that they've chosen is the correct antibiotic for that particular patient. And if this is the first time ever that you've had a UTI and you have no other complicating factors, just going to your PCP or GYN, providing a clean catch sample, and getting treatment if necessary is reasonable. But if that infection doesn't go away, or it returns in a short period of time, or you have 2 in 6 months or 3 in a year, as we talked about, you really need a more complete evaluation. Many women showing up at their PCP or GYN provide a urine sample and aren't given any type of exam. And there are so many other things we talked about that potentially can mimic feelings of a UTI, especially in perimenopausal or menopausal women. So an exam is necessary at this time. So most PCPs or GYNs kind of have an arbitrary number in their head. They'll treat a patient's UTI, they'll treat it a second time, but if they come back a third time, they usually send them for specialty testing at that time, or if they have to see them too many times, whatever they determine is too many times, then they may finally get sent to a urologist or a urogynecologist like myself. A second location patients may show up in is urgent care, because without fail, UTI symptoms tend to happen in the evenings or on the weekends when your typical doctor's office is closed. In an urgent care, they're also going to run a urine dipstick, as I mentioned before, and provide treatment if it's appropriate. They may send a urine culture, but not always. And when a patient continues to go to urgent care, one of the problems is sometimes she's going to one urgent care for the first infection and a different urgent care for the second and a different urgent care for the third. Even if she's going to the same urgent care every time, it's really difficult for me as a specialist to gather all the testing and records from the urgent care to see if they actually did any testing. Urgent care, as it sounds, is like a freestanding ER. They're not there to give you comprehensive care. They're there to treat the problem in front of them. So if you go into an urgent care, you say you have a UTI, they do a urine dipstick, it looks like you might have a UTI, you may get antibiotics and be sent home and no other testing is done. And if that happens 2 or 3 times and finally you come to see me, I really don't have any data to work with. All I have is that you've been treated 2 or 3 times in a short period of time. The final resource a woman may use if she has a UTI is telehealth. These are the video doctors or a call-in doctor. Sometimes your insurance company may have a number you can call and speak to a nurse to get health care. Now, obviously, if you're doing telehealth, you're definitely not getting an exam, and you're certainly not getting any urine testing. This is a provider hearing about your symptoms, hearing about your history, and possibly sending in an antibiotic. As I mentioned before, if you're a young woman with no other issues, it's the first time ever you've had a UTI, or you had one years and years ago and you have one now, and telehealth is your only option, that may be fine. But once again, if it's repeated, if you are an older woman with menopause symptoms and those aren't being treated, it's really important not to only use telehealth to treat your UTIs. A physician really needs to do an exam and do some testing to help treat you properly. So when a patient is sent to me with a concern for possible recurrent UTIs, my first question is it really recurrent UTIs? What testing has been done, as I just mentioned? Is it just that you've been treated 3 times in the last 6 months, but no one did any testing? Or have you been treated and tested each of those times, and each of those times we've proven that it is a bacterial infection of the bladder? Of course, I want to make sure that it's not anything else. There is a condition called interstitial cystitis or painful bladder syndrome. You can listen to my other podcast where I go into detail about what that is, but that is a condition that can mimic UTIs, but very often the cultures repeatedly come back negative. I also want to do an exam to look for evidence of atrophy and treat that if it's present. Look for presence or absence of vaginal infections. Look to see if you have a kidney stone or a bladder stone or something else that could be mimicking these UTI type symptoms. But most women, other than a physical exam and the proper type of urine testing, don't need much else in the initial evaluation. Sometimes patients will come to me and tell me, my primary said I need a cystoscopy. A cystoscopy is a quick test we do in the office where we use a tiny little camera to look inside at the bladder. And I do this test many times a day, many times throughout the week. But for most of my patients with recurrent UTI, it doesn't add very much to making the diagnosis. I only add a cystoscopy when I'm looking for something else, like maybe she has a bladder polyp or a bladder stone or something that I'm concerned about. But for just UTIs, a cystoscopy does not add much information. So once a patient does have a clear diagnosis, they truly have infections and they are repeated, my first job is making sure I get rid of the active infection. And usually for these patients, as I mentioned, this is where molecular testing or PCR testing is really helpful. I want to make sure that any pathogenic bacteria remaining in the urine are treated and that the patient's symptoms are gone. Once we reach that time, okay, we've got the active infection under control. We now want to switch gears and talk about prevention. How do we stop these UTIs from coming back? Because once you've had 2 or 3 in a row, you do not want to continue on with them. As I said, they always occur at the most inconvenient times when you're on vacation, when you're on the weekend, when you can't get to anyone. One of the first things I'll do for my menopausal women, almost across the board, without fail, without even thinking about it, is begin vaginal estrogen. There is definitive evidence for the use of vaginal estrogen reducing the chance for recurrent UTIs. You want to consider adding vaginal estrogen even if you're a woman already taking systemic hormone replacement therapy. Systemic meaning whole body. This would be estrogen that you're taking by a patch, a cream, a pellet, something like that. Because very often those systemic doses of estrogen are just not concentrated enough for the vagina and the bladder. We need a specific dose that is just going to fill up the receptors in the vagina and the bladder and keep that tissue healthy. So adding vaginal estrogen is almost a knee-jerk reaction for me in any menopausal woman with recurrent UTIs. It works in so many positive ways. It increases the healthy lactobacilli in the vagina, and those are the normal bacteria that are supposed to be there that prevent infection. Even though we don't have data to support this, I believe it probably also increases the healthy lactobacilli in our bladder, and those should be the healthy bacteria that prevent bladder infections. It also increases tissue thickness. It brings good blood flow to the vagina and the bladder. And when we have thicker, more flexible tissue, that can make a physical barrier to bladder infections. And vaginal estrogen also treats other symptoms of genitourinary syndrome of menopause that very often can mimic UTIs, like urinary urgency and frequency and vaginal irritation. A lot of times those symptoms are interpreted as a UTI, but they are not. And as I said, we don't want to be overtreating our patients with antibiotics. So using vaginal estrogen to treat atrophy and the other symptoms of menopause at the vagina and bladder is a good option. The next thing I want to do is test for a low level of bladder bacteria that might be embedded behind a somewhat impenetrable layer called a biofilm. There's a lot of data going on about the biofilm and what it's made of and how we penetrate it, but we do know that it is likely that in patients who have frequent infections, some of the bacteria can learn to resist treatment by hiding themselves from our immune system behind this biofilm layer. There is urine testing that we can do to see if you have bacteria hidden by a biofilm. And our best option for prevention of future UTIs, if you have a positive test for that biofilm, is probably suppressive antibiotics. I spend a lot of time talking to my patients about the difference between treatment antibiotics and suppression antibiotics. Treatment antibiotics are regular dose antibiotics taken 2 times a day, anywhere for 3 to 7 days. That's when you have an active urinary tract infection and you need to rapidly decrease the number of bacteria. Suppression antibiotics are very low dose antibiotics that you only take once a day, but for a longer course, somewhere between 3 to 6 to 12 months. This low level of antibiotic you can think of as slowly chipping away at the biofilm, poking little holes in it so that finally your immune system can get in there and wipe out that low level of embedded bacteria. And suppression antibiotics have been shown to statistically reduce the chances of a recurrent UTI in patients who have frequent UTIs. So, proper suppression antibiotics, I think, are a valuable tool. A lot of my patients are always worried about taking a 3-month or 6-month course of antibiotics, and I have to remind them it's all about the dosing. At this once a day, very low dose, we don't disrupt the GI flora, so we're not going to have GI side effects. We don't disrupt the normal vaginal flora, so we don't see yeast infections. And we do not create resistance from bacteria to this particular antibiotic. So we need to be prescribing suppression antibiotics in the correct dose and following our patients so that we can take them off the suppression when we feel that the biofilm has been disrupted. Finally, I wanted to go over some common myths that some of these are so ingrained in women's lives that it's almost impossible for women to believe that these are not true. But when you have a UTI, someone will always tell you, well, just drink more water and flush it out. And there's nothing wrong with drinking more water and diluting your urine and helping to flush out bacteria there. And there are some studies that do show a trend that increased water intake can decrease your risk of UTIs. But it's only in women who were drinking less than a liter of water a day when they increased their water intake to 2 liters a day. So there's no harm in increasing your water intake to 2 liters a day, especially if you feel like you're prone to UTIs or if you're symptomatic with a UTI, but there's not strong data for it. The next two are the ones that I hear all the time. One is peeing right before and immediately after sex. You've got to empty your bladder before you have penetration, and you've got to empty your bladder afterwards so that any bacteria that got pushed in there, you're going to pee them back out. This has actually definitely been studied, and it makes absolutely no difference. So I have these poor women who are just petrified of getting a UTI, who pee immediately before sex, and the minute they're done, they jump up and go to the bathroom and urinate again, and sometimes they're even showering and scrubbing themselves down, and then they're so frustrated when they get another UTI. And I really have to break that guilt cycle by telling them, you are not doing this to yourself. It wasn't that you took too long to pee or you took too long to take your shower after sex. That literally has nothing to do with it. If you have a biofilm, if you have that embedded bladder bacteria, you're going to get a UTI no matter what you do. The next one is wiping direction. I think all women from a very young age have been told, wipe from front to back. Don't wipe from back to front or side to side or any other way. And this also has been studied. unless you have obvious fecal soiling, in which case you should wipe that area separate from the bladder. There really is no difference in the direction that you wipe in causing or preventing UTIs. And that's probably because the bladder opening and the rectal opening, by nature, are very close together. And we know that there are tons of E. coli that live in the colon, which means there's tons of E. coli living on the skin around the anus, around the vagina, and possibly around the bladder. But that should still not be a reason for women to get recurrent UTIs, because 100% of women have E. coli living around the bladder opening, but 100% of women do not get frequent UTIs. So there has to be something else going on. So when you go to the bathroom to urinate, if you're comfortable wiping from front to back, that's fine. If you go to the bathroom and you have a bowel movement, I would say wipe your rectum separately and kind of away from the bladder. But other than those obvious fecal soiling times, wiping direction really makes no difference. Cranberry juice is another thing that women have been recommended to take if you're prone to UTIs or even when you have a UTI. Cranberry has been studied and the data is just not overwhelming. The AUA, the American Urologic Association, says it's safe to use, but there's no real strong data saying that cranberry tablets or juices or supplements are going to reduce your chance of UTIs. And if you are using a cranberry supplement, especially a juice version, watch out for high sugar. Cranberry is so tart that to make it palatable in a juice, you have to add a decent amount of sugar. And sugar has been shown to increase the risk of UTIs because the bacteria feed on that sugar and can multiply. That's why our diabetic patients who have high sugars and uncontrolled sugars tend to have more infections. So watch out for cranberry. Don't worry about spending money on expensive cranberry supplements. They're likely not to help. The final thing I get asked about is probiotics. And once again, the data that we have as of now do not support the use of any probiotic to reduce the chance of UTIs. Just like cranberry, there's probably no risk in taking it. You're not hurting yourself in taking it. But some patients are spending so much money on probiotics, or they're getting the ones that you have to put in the refrigerator, which are even more expensive, or they're changing the formulation of their probiotics. And as it stands today, we just don't have overwhelming data to say that it makes any difference. Now, the reason I say as of today, things change in medicine all the time. We may at some time learn about how to properly populate the bladder with the correct mix of lactobacilli that it needs to improve its immunity. So there might be something in the future that I feel is valuable to recommend. If you do need to take a treatment course of antibiotics, that's that twice a day course of antibiotics for 3 to 7 days, it's probably not a horrible idea to take a course of probiotics after that, because that treatment dose of antibiotics, because it's higher dose, is more likely to wipe out some of our healthy bacteria. But when you take a course of probiotics, take it for a month, repopulate the healthy bacteria, and then they should be able to maintain themselves. It shouldn't be something that you have to take for the remainder of your life. So my office is preparing in December for the increased number of UTI calls that we're going to be getting, but hopefully you can take some of this information if you are a patient prone to UTIs and dispel some of those myths that you may have heard for your entire life, and also make sure that you get to the right place for testing and treatment if you are a person prone to UTIs. Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.